Hi all, welcome back. And for the final kind of piece of bone tissue, I like to talk about, well, now you've learned about the cells, you've learned about how these cells go about laying down bony material, how does it grow, how is it replaced. Now we're going to talk about, well, what happens if there's a mutation, or what happens if there's a disease, or different things that occur, disorders that are related to bone. Okay, the first one I kind of want to talk about is dwarfism. Okay, and dwarfism comes in kind of two forms. One which we call achondroplastic dwarfism. Okay, and this is what results in long bone problems. Okay, so your long bones stop growing. The cartilage that occurs in that epiphyseal plate doesn't lay down. It doesn't transfer into the metaphysis, or where the bone would replace that cartilage. So what happens is your the long bones don't extend. The long bones stop growing at a very young age. Okay? The flat bones, on the other hand, those flat bones continuously grow, okay? And they get to normal size. So what you have is an individual that has achondroplastic dwarfism. They have short limbs, or their limbs tend to be shorter, but their torso and their head all look like they're normal size. And so that's if you see someone who has dwarfism, and it looks like they have a normal torso and normal head but short limbs, okay, it's a chondroplastic dwarfism. Okay? And it's due to a mutation in the alleles that are associated with cartilage growth. Okay? And can Of course, it can cause complications for individuals. Okay? The other type is pituitary dwarfism, which is also related to a mutation, but a mutation in the pituitary gland that's going to release GH, or growth hormone. Okay, so in all cases, growth hormone is a stimulating hormone that stimulates the addition of material to your bones. Okay, so it stimulates the growth of all the bones, even flat bones and other things. And so pituitary dwarfism, what occurs in that, instead of having a normal torso and normal size flat bones in the head and things like that, all the bones are smaller. Okay, and so the lack of growth hormone means universally the individual is shorter in stature, and so all bones, long bones, flat bones, all the other bones that are not kind of have their own specialty bones, they're all affected by this. Okay. All right, let's talk a little bit more about bone remodeling. Okay, I told you that you're continuously remodeling your bones throughout your life. In fact, it's about a 10% replacement per year. Now, this will slow down and there will be less replacement as you age, but after 16, 20, depending on the sex of the individual, you're replacing about 10% of your skeletal system every year. Okay, so that means bones being removed and bones being laid back down. Okay. Now, part of this remodeling is really important because at times you might have some bumps, bruises, falls, these kind of things that create micro fractures. Okay, and that create those little teeny fractures around those osteotones, okay, or through those osteotones, through the concentric lamellae of the osteotome. And by replacing, reabsorbing, destroying some bone, and then replacing that bone, you fix a lot of those microfractures. Okay? And so that's really important. In addition to that, is over one's life, you tend to, not all the time, but most people tend to increase in mass, increase in weight. And when you increase in weight, you're putting a different mechanical stress on those bones. And so the bones need to adjust to that different mechanical stress. So as you age, often you're putting more weight on those bones. Those bones are transferring from spongy bone into compact bone in certain regions and kind of building more bone that can take and uh, allow for that bone to be reshapened so it can take the new stress that's being put on the bone by an increase in mass. Now, it's not just an increase in mass, it's just an increase in lots of things. Maybe it's not mass because maybe you're not putting on lipid mass, maybe it's not fat mass, but maybe it's muscle mass. And as you get older, your muscles are getting larger, and so you're getting more stress put on those bones from a different muscle. Same deal. It's still Wolff's Law. Same thing applies. Okay, that if your biceps are getting bigger, you're going to put more stress on the bones associated with your bicep, and so you might see that the humerus is getting larger. It's getting the spongy bone portion of the humerus might be transferring into more compact bone. Okay, it's not elongating if you're past really the age of 20 if you're a male, or 16 if you're a female. It's not elongating anymore, but the girth, the kind of the mass of the bone is becoming more compact. Okay? And that remodeling, we already talked about it. The remodeling is really just a combination of osteoclasts removing bone material, so they're excreting digestive enzymes, which removes the bone material, and then osteoblasts laying down new bone material, okay, collagen fibers that are going to become osteophyte. And then, of course, we already talked about Bone's Law, or Wolff's Law of the bone, and that's really the more stress you put on a bone, the greater need for that to be rearranged and remodeled. Okay, so let's talk a little bit about how this mineral deposition occurs or mineralization occurs. Okay, we've already talked about what's the building blocks to bone. Okay, we know it's calcium, it's phosphate, there's some other ions. Okay, how is it laid down? Okay, osteoblasts, like I said many times, just reiterating it, they're going to lay down collagen fibers. Those fibers are going to be in kind of a spiral staircase down the osteotome, and it's going to go clockwise, and then the next one will go counterclockwise, etc. Those fibers will be encrusted with minerals, and the first few mineral pieces that attach to that collagen fiber are what we call seed crystals. Okay? And these seed crystals are really important because they attract other molecules of calcium and phosphate from the blood that's flowing in that region. Okay? And so this is why at a young age, children are told to drink milk. Okay? And why, in the case of mammals at least, why we have mammary glands and have milk associated with our body to feed our offspring is because it's high in calcium. Calcium is needed to build bone. Phosphates also obviously needed to build bone, but you can pick up a lot of phosphates from other things, other components in your diet that are coming from phosphates, whether that be protein or carbohydrates. A lot of them will have some phosphates associated with it. So it's the combination of that calcium phosphate in solution that's attracted to those seed crystals. Now you can have situations though where you might have too much calcium in your body. And this might happen as you get older. Maybe if you continuously drink a lot of milk, then it is possible that, or if you have a disorder, it is possible that you can get calcification of other tissues. Okay, and this can be very damaging depending on the tissue type. And can result in some abnormal kind of actions, whether that be the brain or in the lungs or the eye, the arteries. If you get ectotropic ossification, or when calcium builds up in these tissues. And then, of course, there's other tissues that it can build up, and that's calcalis. And that's going to be calcified masses that occur in softer organs. So maybe like your liver, you might have a calcified mass that occurs in your liver or your kidney, or different regions of your body that can just develop these structures. Often it's not a huge deal. Often the body can react to it, can kind of move around it. Not a big deal, but there are certain circumstances in the brain, the eye, the arteries, that it can cause damage to that. Okay? There are ways, though, that our body determines whether or not you have too much calcium in the blood or not enough. And that's called homeostasis. Just like thermohomeostasis or salt homeostasis or pH homeostasis, calcium homeostasis works the same kind of way. If you have too much, you're going to have things that can be corrected to remove the calcium. If you don't have enough, you have ways in which you can correct it, so you can add calcium back into the bloodstream. And really that comes from a few different ways. Okay, so you can have calcium that is deposited in urine and in fecal material. Okay, so your kidneys can determine how much calcium is going to be urinated out or excreted out. Same thing with your intestines, can determine how much you're losing in the fecal material. And then, of course, you can have an association with your bones, the osseous tissue. Okay, and we'll come back and talk about all these. Okay, there are three main hormones that are associated with this homeostasis. Okay, calcitorol, calcitolone, okay, and the parathyroid hormone. Okay, all of which have different ways to regulate calcium homeostasis. Some which only react to when calcium's high, and others that only react to when calcium is low. Okay, so we're going to go through each one of these and kind of talk about how they work. Calcitorol, or what we normally just label as vitamin D, okay, is important for a few different reasons, but one of the main reasons it's important for is to react to calcium that's in the body, okay, and if you need calcium to be reabsorbed in the bones, calcitorol will be associated with that. How do we get it? Well, this is one of the molecules that are associated with UV light. Okay, so UVB light will react with a dihydrogenase cholesterol, 7-dihydrocholesterol, that will cause the molecule to change shape. So UV radiation is good at breaking bonds and having the bonds kind of reform. And that's what occurs. When it does, it's called cholecalciferol, or vitamin D3. That cholecalciferol is going to then be moved to the liver, right? While in the liver, it picks up a hydroxyl group. Okay, that's that OH right there, and it becomes calcidiol. Okay, and then it moves into the kidney, picks up another hydroxyl group, and now it becomes calcitrol. Now it can react in different regions. It can cause calcium to be reabsorbed in different places. It can reduce how much calcium is being excreted out through fecal material, through urine, and it can cause calcium to be reabsorbed in the bone. Okay? Now, calcitrol, okay, when you have issues with it, you can have an issue with it as a juvenile, as a young individual. Sometimes it pops up, or as an adult, and you have different ways at which this works. It's necessary for the adding of bony material, okay, and in particular, the adding of compact bone material. Okay, so when you have issues with calcitrol, what happens is you don't have enough calcium and phosphate that's coating those collagen fibers. So you're not getting the inorganic material that's building bone. Okay? You might have the organic material just fine, but the inorganic material is missing or limited, which causes the bones to be soft. Okay? And that softness in bone plus gravity can cause an individual's bones to bow. Okay, and so rickets is a example in children of this abnormal, inadequate calcitrol, which is going to cause less calcium and phosphate to be associated with the collagen fibers. They tend to be weaker, they bend more, and you can get these bowing of the bones. It can also happen in adults, osteomalacia, um, but it's much more common um, in children, and you see it a lot in developing countries where uh, there may not be both enough calcitrol in the individual, or they may be missing enough calcium and phosphate to begin with, and so there are different ways in which this might play. Okay, calcitotron, it's a different kind of molecule. It's like it works in kind of a different fashion than calcitrol. It's released by the thyroid gland, or is associated with the thyroid gland, and it's secreted when blood calcium levels are too high. So calcitrol is reaction to blood calcium levels too low. Calcitotron is a reaction to too high of calcium levels. Okay, and so if your calcium levels are too high, there are a couple ways at which your body goes about, and ways at which this hormone entices your body to start doing things. One is osteoclast inhibition. So the outside of all your different cells, they'll have binding proteins that recognize different molecules. And what can occur is, if these hormones are being produced, they can inhibit the formation or inhibit the ability for certain things like osteoclasts to work. So they'll bind to the osteoclast, and then the osteoclast can't continuously reabsorb or dissolve bone, okay, which will reduce the calcium that's being put back into the blood system. Osteoblast, okay, it stimulates them. So it starts to stimulate calcium to be laid down in the bone. Okay, so one, it inhibits the addition of more calcium, and the other one, it entices the things that use calcium to start depositing more calcium. It's important in children, typically not seen that much in adults. And that really has to do with just the amount of osteoclasts that you see in children. Osteoclasts are way more common in children because children are constantly remodeling their bones. Okay? As their bones are growing, the children are constantly remodeling it. But that being said, there has been some recent publications about the role that calcitriol might play in pregnant and lactating women. Okay, and often they will be associated with a loss, a bone loss, and so there might be a way at which either injecting them with this hormone can stop kind of the bone loss that we see in certain individuals. Okay, so here's just kind of a flow chart of how that works. You have a bunch of extra calcium in your blood. Okay, that's going to entice uh, the production of calcitriol and the excretion of it. Okay, it's going to get into the blood system. It's going to go to different regions of your blood. It's going to stop the osteoclast activity. Okay, so you have less bone reabsorption. It's going to increase the osteoblast activity, so you have more bone being deposited. Okay, and that in turn will cause the calcium levels to decrease. Okay, pretty simple. The last one is parathyroid hormone, and this hormone is released by a parathyroid gland, which is right next to your thyroid gland, and it also reacts to low calcium in the blood. Okay? When it does that, when it reacts to it, it has four kind of mechanisms to increase calcium in the blood. First, it can bind to the receptors on the osteoblast, so it makes it so they can't use calcium. Okay, so that holds the calcium back into the blood. Okay, and stimulate osteoclasts to reabsorb bone. So it's the opposite effect of calcitonin. Okay, it can promote calcium reabsorption in the kidney. Okay, so again, I told you that we lose a lot of calcium in urine. Okay, so it can promote the reabsorption of that calcium, so less is lost in the urine. Okay, it can promote calcitriol synthesis in the kidney. Okay, enhancing the calcium raising effect of calcitriol. Okay, and then it can inhibit collagen synthesis by the osteoblast. So no, not only will it not allow the osteoblast to kind of work by attracting calcium and phosphate, it also just stops the collagen synthesis, so it can't build any more bone. And so it works kind of in four different ways. And this is what it would look like. So if your blood is deficient of calcium, the parathyroid hormone is secreted into the blood system. Okay? And again, one way that it can work is increase the osteoclast activity. If you do that, more bone is being reabsorbed, so more calcium's going back into the blood. You could reduce your osteoblast activity, less bone is being deposited, okay, so the calcium stays in the blood. You can have your urine excrete less calcium and maybe more phosphate. Okay, and that will prevent the hydroxyapatite from forming, so you're not using up those molecules to make those seed crystals. Okay, so that in turn will have less bone deposited, so more calcium can stay in the system. And then of course you can have less urine or less calcium in your urine, and you conserve that calcium, and that goes back in the blood system. Okay. All right, so in general, those are kind of some disorders and diseases. You can have problems with your parathyroid. You can have issues with some of the other ways at which hormones are going to be associated with bone um, growth and reduction and whatnot. But then we have repair and just generalized repair of, well, what happens if you break something? And so that's orthopedics. Okay, deal with that. And we can classify fractures in two main ways, although there is definitely some crossover between these two. Okay, and so one is what we call a stress fracture. Stress fractures are breaks that are due to abnormal trauma. Okay, you fall down, you get hit by something, that kind of thing. Abnormal trauma. Pathological fractures are due to weakened bone. Okay, by diseases, either internal or external components of those diseases. Okay, it could be genetically controlled, etc. But the bone is not healthy, and the bone tends to um, deteriorate over time. Now, these two can work together. Okay, so you can have some osteoporosis and then have a fall and create a stress fracture. Um, okay, so they are related to each other, but a little bit different. Okay, fractures can also be classified on what structure or how has the structure been fractured or broken. Okay, and so the fracture line, okay, is it non-displaced or is it displaced? Okay, so I'll show you a picture of these two in a second. Or how's it cracked? Is it just cracked or is it broken multiple pieces? Okay, so is it comminuted or is it a green stick fracture? Yeah. So if we look at a non-displaced, non-displaced means the fracture, the break, it's clean. Sometimes that's exactly what it's called, a clean break. Okay, it means the lines there, the the bones are not displaced from each other; they're still held in place. Okay, so that means the muscles and the tendons that are associated with are holding the bones right where they should be. The ligaments, that it might be in this region, same deal, kind of holding the bone where it should be, and the bone is non-displaced. Then you have displaced. Okay, so it's a force that's broke the bone, and then the bone is moved away from the other side, or vice versa. Okay, comminuted, which is going to be broken into pieces. Okay, and then green stick, we already talked about this. That's where you have a fracture that doesn't go all the way through. Okay, and you have like a partial fracture of the bone. Okay. All right. So how's it healed? Okay, so the first step to heal a bone fracture is to produce a hematoma. Okay, and this production of hematoma, or the production of hematoma, is partly due to this region. Remember, this region has blood flow, and what's happening is when you break this, you damage the blood vessels and the capillaries, and that's part of that hematoma. Hematoma is a fancy word for a bruise. Okay, so you get that material is being expelled out of the blood, and then platelets will go and seal it off. But then you're also attracting more blood to the region. Okay, and so that's important because more blood means more nutrients, which means the process can heal faster. Okay. Then what can occur is a soft callus will form around the wound. Okay, and this is just fibrocartilage that's being laid down to kind of hold the structure in place and provide kind of a kind of a protection piece around the break. And you'll see that this soft callus becomes a hard callus the next step. So that hard callus forms. Okay, so osteoblasts will start to deposit what we call a bone collar around. And so most of the time this is temporary, although sometimes not temporary, but that it'll form like a hard bone callus, compact bone on the outside, and then the inside you'll start to see the formation of spongy bone. That spongy bone, okay, depends on where it's at. May still reside in the middle, okay, but after a period of time, that spongy bone is converted into compact bone, and that callus will be deteriorated. So osteoclasts will come in and start removing that callus. It depends on the individual. Some individuals, the callus doesn't get removed and it stays, and it becomes kind of a permanent marker. And it really depends a lot on diet and where's the break and the nutrients in the individual, how old the individual is, lots of different situations on whether that callus is going to be removed. Treatment of fractures, okay, a couple ways at which this occurs. You have what we call a closed reduction, which just means that the bone fragments can be manipulated back into place without surgery. So if it's a displaced bone, you can just palpate it back into place, and that's considered a closed reduction. An open reduction means that you have to do a surgery, you have to open them up, okay, and you are normally, if you have to open them up, you're going to have to fix or have a internal fixation. So these are called ORIFs. And they will result in pins, screws, some kind of bonding agent that helps bind the bones together. There are some news sources out there that are suggesting certain types of glue, and if that's the case, maybe you wouldn't have to do 2 surgeries, because most of the time, one surgery is to put the screws, plates, and pins in, and then another surgery to remove the screws, plates, and pins afterwards. Okay, and so here you can kind of see the screws and plates in this x-ray here. And then we have this association often with the parathyroid hormone, okay, that sometimes the parathyroid hormone can cause a wound to heal slower and a bone to come back slower, just because of the reaction of the parathyroid hormone. So sometimes when fractures have lasted quite a while, maybe 2 months or so, sometimes electrical stimulation will suppress the effects of the parathyroid hormone. Just depends. It depends on where you get healed, where you go to get this done. Sometimes they don't do this anymore, but other times they do. And lastly, what I want to talk about is osteoporosis and other things that are associated with net loss of bone as an individual ages. Okay, so again, that 10% rule where you're basically regenerating 10% of your skeleton year after year. After about age 40, it depends on the individual, depends on the sex of the individual also, but the net loss of bone, it outpaces kind of the laying of bone down. So the reabsorption process outpaces deposition process. So you're year after year, after about age of 40, you're reabsorbing more bone than you're laying down. So your bones are not getting thicker, they're getting thinner. Okay? Now, there are lots of contributing factors to this on whether this occurs or not, and it's greatly determines on the sex of the individual. Women by far are more affected than men, normally because this has to do with hormones that women have that men do not or have less of. Individuals with small, light frames are affected more than heavy people. Okay, if you're small and light, your 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 bones are already less dense, and so Wolff's Law is not applying to you nearly as much as if you're a heavier individual. If you're heavier, you're putting more stress on those bones. Those bones are becoming thicker, and so individuals that are really light will tend to have a lot more bone loss, or the bone loss is at least more noticeable for those individuals. Ancestry, okay, again, there's always going to be a genetic component to this. Okay, so typically Caucasians, and so Asian or European descent will often be more vulnerable than some of the other ancestries or ethnicities that we have on the planet. Older individuals, again, this goes back to what we call the Hayflick limit. We talked about it a little bit before when we were talking about how cells replicate. Okay, your cells have a limit to how many times they can replicate. The older you are, the more likely those cells are reaching their limit. And if you have limits in certain regions on how many cells these or how many times these cells can replicate, then it gets to a point where you're just not able to replace the bone, okay, because the cells are not working anymore in that region. Okay, and that really gives us two kind of conditions, one called osteopenia, okay, which means that you have a measurable decline in bone density. Okay, it may, and lots of people will have osteopenia, and it may advance to osteoporosis. And so osteoporosis is severe loss of bone density, which can cause bones to fracture easily. Okay. All right. Next time up, we're going to talk muscle.